Welcome to Mid-Run Pager. My name is Benjamin and today I'm going to be talking about infantile hypertrophic pyloric stenosis. And this is a condition whereby we have hypertrophy and hyperplasia of the pyloric muscle, and this leads to gastric outlet obstruction. So the pylorus is found at the end of the stomach, and it is a sphincter, but it's going to control the exit of gastric content into the first part of the duodenum. So early during neonatal period, if you have hypertrophy or hyperplasia of this muscle, we're going to have an obstruction that we shall call infantile hypertrophic pyloric stenosis. And when we look at the epidemiology and the risk factors, it is most commonly found in males in a ratio of 4:1, and this has been, some theories say that there is increased androgen sensitivity of this pyloric muscle to androgens, and this causes it to hypertrophy. But other risk factors have been recognized, things like bottle feeding, whereby somehow the increased flow of milk or the high flow of milk is considered to be a cause that leads to the increased contraction of that pyloric muscle that leads in end to this hypertrophy or hyperplasia. The early postnatal to azithromycin, the erythromycins, these are macrolides, and macrolides are seen to increase gastric motility because they're agonists of motilin, which is the natural hormone that is responsible for gastric motility. So when we have exposure to this, we can have increased activity of this pylorus, which leads to also hypertrophy. Then maternal smoking has some interference with the development of the enteric nervous system, which is responsible for the inhibitory relaxation of the digestive system. So when we have smoking in maternal pregnancy, it may have some interference causing this hypertrophy of the pylorus, as well as the family history, whereby we see that in families where we have had this, it can commonly occur. So when we look at the pathophysiology, we have progressive circular muscle hypertrophy of the pylorus, and then because of these circular muscles, they are circular around the pylorus are hypertrophying, they're going to have a functional gastric outlet obstruction, which means it's just the contraction of the wall around there that is causing the obstruction, and this is going to lead to persistent vomiting. Whenever this child has eaten, they're going to vomit, and when they vomit, we're going to have electrolyte and acid-base disturbances coming in, and most commonly you're going to have hypochloremic because the gastric acid is not getting to the intestines, hypokalemic, metabolic acidosis, and then we can have a paradoxical aciduria, and this is aciduria, and this is a lead finding. And then we shall also have things like delayed gastric emptying, and this can be also manifested as visible peristalsis. So when we look at the clinical presentation of these guilds, most of the time we have projectile non-bilious vomiting, and this is after feeds, and this is the major hallmark. So this child has a non-bilious vomiting that is projectile, and the vomiting becomes more and more forceful over the days, and the infant remains hungry after vomiting. So this infant, after vomiting, they come back and feed with a lot of vigor, who we call the hungry vomiters. Then we have constipation, of course, because things are not going downstream, or decreased stools. And then weight loss is going to ensue, and poor weight gain. Then we can also have possible signs of dehydration, and these are children, so things like a sunken fontanelle, lethargy, and other signs of dehydration in children are going to set in. So when you do this physical examination, this is very important. We have a palpable olive-shaped mass in the right upper quadrant, or epigastric region, and this is pathognomic. So what happens is that when you're examining this child, you want to trace the liver edge and try to displace it away and try to feel around that area where we expect to have the pylorus of the stomach, and this pylorus is going to be hypertrophied, and we shall perceive it as olive-shaped mass. And then when you look at the stomach, sometimes you may see visible gastric peristalsis, and this is going to be from the left to the right. Then we shall have signs of dehydration, we can have a dry mucosa, a sunken fontanelle, and a delayed capillary refill. So investigations we're going to do, the blood tests are very important, and we're going to assess the hydration and the electrolytes. So we shall find that the chloride is low, potassium is going to be low, the bicarbonate is going to be high. Then overall we are going to have a metabolic alkalosis. You may have possible hypoglycemia and prolonged vomiting because things aren't going down. So it makes sense that we are not absorbing glucose, so the child is going to get hypoglycemic. Then on imaging or ultrasound, we find that the pyloric muscle is thick, greater than 3 millimeters, and the pyloric channel length has increased greater than 14 to 17 millimeters. Then we have target or the donut sign, and this one is what we normally may appear in examination. So it's high yield to know the target sign or the donut sign. Then when we do an upper GI contrast study, we may see what we call a string sign, and then we have delayed gastric emptying and shouldering of the pylorus. Then when we go to the differential diagnosis, we can have things like GAD and duodenal atresia, but when we have duodenal atresia, most of the time we have already reached the point where the bile has entered the intestines, so we have bilious vomiting. We can have things like annular pancreas, malrotation with volvulus, milk protein intolerance, and most commonly, a lot of practitioners or mothers will keep changing the formula. If this child has been feeding on formula, they will keep changing the formula, thinking that your child is intolerant, when actually they could be having this hypertrophic obstruction. Then metabolic disorders that cause vomiting can also be a differential. So preoperative management is very, very important, and this is the real emergency, not the surgery, because this patient is coming in with a metabolic alkalosis and dehydration. So we want to correct that. So we want to give IV fluids, a bolus of isotonic saline, and then we maintain them of half strength normal saline, dextrose, and potassium chloride that is going to be put in their fluids. And we aim to normalize the chloride to greater than 95 milliequivalent, the bicarbonate to less than 30 milliequivalent. Then we insert NG tube if the vomiting is persistent, and then only proceed to surgery when the child has stabilized. So the definitive management in this case is what we call the Ramstead pyloromyotomy, and it can be done open or laparoscopically. And what happens is that the splitting of the hypertrophied mucosa, the splitting of the hypertrophied muscle down to the mucosa, but we do not open the mucosa, so we leave it like that, and the success rate is about 95%. The postoperative care, you want to gradual introduction of feeds, and this is usually within hours, and then mild vomiting postoperative should be expected, and it does not mean that we have failure, so the vomiting may persist a few more days. Complications before treatment, we may have severe dehydration, electrolyte imbalance, metabolic acidosis, and failure to thrive. Then postoperatively, you can have an incomplete pylorotomy, which gives you persistent symptoms because of perforation and wound infection. So the key points to recall when it comes to infantile hypertrophic pyloric stenosis is projectile non-bilious vomiting. Whenever you have projectile non-bilious vomiting, you want to assume it's that infantile hypertrophic pyloric stenosis until proven otherwise. Then the metabolic disturbance that we normally have is hypochloremic, hypokalemic, metabolic acidosis. The best imaging is ultrasound, and the pyloric thickness is greater than 3 millimeters. Always correct electrolytes first before you do the operation. And whenever you have a hungry vomiter, an olive-shaped mass, and visible peristalsis, this is the classic triad of this condition. So you've come to the end of this video. I hope we have learned at least something about this. If you enjoyed this video, leave a like, leave a comment, subscribe to the channel if you have not done so. Till we meet again, my name is Benjamin, and this is Made One Picture.